Okay, folks, we have possibly one of my favorite humans on today, and I legit have a girl crush on her. And like all good things that happen at ASHA, we met in the bathroom, I think in Orlando. I
I think it was Orlando.
think it was Orlando.
In the men's bathroom.
Yes, because when you gotta pee and there's no boys around, who cares? Also, I have peed when there are boys in there, but like I gave birth twice, and when I gotta go, pelvic floor therapy says go.
Pelvic floor therapy says go. And yes, the bathroom line was significantly shorter in the men's
Yes, it
bathroom. So
was. But y'all, we have a powerhouse on today. So I am honored to have my dear friend, our dear friend, because Erin's joining us, Emily Justice. And her testimony as a speech language pathologist, working in the NICU, setting up PFD in the public schools in Boston with her dear colleague, Sasha, and all of the work that she's done with Dr. Humbert for teaching evidence-based practice. And you led the installation of the baby steps program. That was your baby, like no pun
yes,
intended, but
it was my baby.
yes. And I had the honor of watching her talk to my speech babies this summer with North Carolina Central University and watching her fill the cup, literally, of the next generation of colleagues that are going to enter this. It was, oh my gosh, you have the biggest fan in some of my speech babies, and they kept coming back with, like, oh, well, Miss Emma gave us this recommendation, and Miss Emma gave us this recommendation. And I was like, yes, but she has created this safe space for learning for all minds and for all kinds. And you give back with March of Dimes. Okay, so fangirl, and you always are zesty and fabulous and hollered at me in Boston as if I knew no one in Boston in the middle of the street. And I ran out into the street like on another Asha. And
I forgot about that. Yes, I did. Yelling at you in the middle of the street as I was driving, beeping. Yep.
yes, but
Classic
no,
Bostonian fashion too.
yes, but God, I am so grateful for you on so many levels. So, hello, welcome. Thank you for
Hello.
coming on.
That was a beautiful introduction. Thank you so much.
Yeah.
It's funny because you forget little things, but you always bring them back to my attention, which is lovely. The ADHD brain, right? We share the common ADHD brain.
You remember those details.
Remember the little details, and the little details I don't remember you do, and vice versa. So it works out.
Yes.
It works out.
So take us from the beginning. What made you become a speech therapist?
Yes, I'll give you my little spiel. So I am very open and transparent about my journey. I think that it's very important. I'm very passionate about a lot of things, as you just opened with, but I am very passionate about, the recruitment and retention of minorities in this field, right? And I think that we're getting better. Every year we get a little bit better. I think the percentage right now in 2025 is about 9.5%, and this varies. That varies from, non-Caucasian SLPs, right? So, if we're looking at men, we're looking at Black people, we're looking at Hispanic people, we're looking at non-Caucasian SLPs. So my background, I am adopted, and I was adopted from the NICU. So I was a NICU baby, and I was an NAS baby. So I like to bring that full circle, right? I think that many of us work with the little babies in the neonatal population and work with, or NICU graduates, right? So babies that were previous NICU babies that have a lot of developmental concerns. So now I like to bring it back full circle. So that's kind of what drove my passion to get into this field, and that was always my goal. Getting into this field was the NICU and working with infants and supporting NICU families. And now I do that, but also, as you mentioned, many other things as well.
Yeah, it's an
Because
understatement.
everything we do, right, we find more problems to address. So every aspect. So, I really got into feeding in the public schools. I'll give that little quick spiel because I as Michelle mentioned, I am from Boston, born and raised. I left for a little while to do my clinical fellowship in Florida and then came back to Boston. And Boston is wonderful, right? It's known as a healthcare hub. It's known for access to resources, right? So, which I love about Boston. However, there's still a public health crisis, right? Where is feeding therapy? We have 4 pediatric institutions within a 5-mile radius, and feeding therapy is very, very limited. Assessment is wonderful. You have access to assessment, access to feeding teams. However, the treatment itself is frequently inaccessible to low income families and mass health families. There are many private practices that will do feeding therapy. However, with mass health, which many of the inner city, right, population has mass health, and
Is
there's
that a
no,
Medicaid for
yes,
Massachusetts?
yes,
Okay,
I'm sorry, Medicaid for Massachusetts, exactly.
okay.
So public health insurance, Medicaid, that is, a good majority. I don't know the exact percentage, so I don't want to speak incorrectly, but we have, the last time we checked, it was around 80% within the Boston public school system. So, that's what kind of fueled my fire to jump onto the feeding team at Boston Public Schools and increase access to care and pediatric feeding therapy within the school system, within the school day.
Yeah. That would be so I just had Dr. Yvonne on. She teaches out at AT Still University, and we were
Mhm.
talking about the social determinants of health.
Yeah.
And that's y'all, this is a real life example of a social determinant of health impacting access to care.
Correct.
And then, oh, by the way, a lot of our medical facilities are already bracing for 2026, the changes of the one big bastard of a bill coming through. It's going to further inhibit access to care.
Access to care.
So, yes. So, I say that because the work that you're doing within the public schools is critical. Because if we have the infrastructure to offer the services when it's further inhibited out in the real world, that we're preventative maintenance, for lack of a better phrase, right?
Preventative maintenance, right?
Yeah.
We are a reactive society. We are not a prevent, right? We do not prevent, we react. And I think that is part of what, as you mentioned, part of my work with Dr. Humbert with Baby Step, right? So, for those of you that don't know, STEP is the Swallowing Training Educational Portal, right? That was developed by Dr. Humbert and Rinke, I want to say 8 to 9 years ago. And it's access, affordable access to dysphagia training. Now, there's nothing that exists for that. Now there is, but previously there was nothing that existed for pediatrics. So for school SLPs, right? I completely understand that from a school SLP perspective. Excuse me, how are you going to expect me to do dysphagia or pediatric feeding when I've had no training at all, right? And how am you're not paying for my CEUs, right? Like we don't have money for, frequently in the public school system, you do not have money for continuing education, right? And
Yep.
if you do, it's given within the school system, right? So it's professional development or it's, required training that's through the district. But to
Yeah.
go outside to a conference, that's a lot of money and it's usually out of your own pocket. So
Yeah.
many SLPs, that's not accessible to travel to pay $800, $1,000 for a conference. So if you can pay $10 or $15 a month and you can get the basics from anatomy and physiology, from in utero development, anatomy and physiology, all the way up to assessment and treatment of the pediatric swallow and assessment and treatment all at your fingertips for $10, $15 a month. And it's about, right now, it's only 4 hours of content. So we're adding more and more, but you can do that in a weekend if you wanted
Yes.
to. Or you could break it up and do it over a few months.
I just renewed my CLC and participated in the Feeding Matter Psychology Summit, and literally in 2 weekends did 26 hours of continuing education. And folks, before we started recording, we were talking about like the light fixtures in my house and how they look like nipples. And, you know, we're fans of nipples here because
We love
baby
nipples.
feeding. But they were talking about pharmacology and toxicology influence on lactation.
Mhm.
And Bear walks around the corner. He goes, "What's meth and why is it bad?" And I was like, I was like, I am not prepared for this conversation.
We'll
So,
talk about that later.
yes, but like continuing education is important, and maybe don't do it when you're making pie in your kitchen and you have to talk about meth with your 10-year-old.
Mhm,
But like,
mhm.
yeah,
But
but
is that not the reality of our lives though,
yes,
right? Like
yes,
how many of us really can dedicate an entire weekend or an entire 4 days to only education, right? We can
yes,
do it, but it's always hard. It's always,
yes.
always hard,
And
right?
it's,
It's so much easier if we can do it while we're making pie, while we're folding laundry, right? While our kids are asleep in the next room.
yes, breastfeeding, nursing,
Breastfeeding,
bottle feeding,
nursing,
the amount of classes I took, like with, yes, but it's accessibility. How do we make it
accessibility.
accessible? And this was, so we were talking about what are we going to cover today? And one of the things that we were talking about was clinical decision making. And what I loved was when she came on and talked to my students. Emily was doing a like in-depth on modified barium swallow studies, instrumentals and their use, but it made me think about her unique bridge, having the ability to do the instrumental swallows and work in the public schools. And now that we're asking speech language pathologists across the country to work specifically on this in the public schools, there is fear of, do I have to have a swallow study first? Right. And which is valid because how long ago was it that they might have taken a dysphagia class?
Mhm.
So the thought was, what are our, can you help us streamline when a child, maybe 3 and up, because I'm thinking school age, when it would be clinically necessary to have a swallow study,
Mhm.
either fees or fluoro?
Yes, absolutely. So, yes, so I'll a couple of questions in there that I am happy to address. This is, I think, frequently a hot topic. I think this topic comes up a lot. And I think there are varying opinions on this. But I think that for the most part, those of us that are speaking about these things or do research in this area are pretty much on the same page. But I do think that it is absolutely very difficult to figure this out, right? If you do not have a strong foundation or a large background in feeding and swallowing in general, right? So if you're new to feeding and swallowing, if you're a newer clinician, or if you're new to pediatrics as well, or working in the public schools, I think that this is a very, very tricky question. When is it appropriate? And what do I refer? What type of test do we actually need, right? And do we need this before we can move forward?
Progress a diet,
Or
because
progress the diet.
I hear that one often, like, well, they're on puree, but shouldn't we progress it? And we should get a swallow study beforehand.
Yes. So what I teach my all my students all the time is we cannot forget about the why, right? We frequently get wrapped up in the what, but
Yep.
we're missing the why. Okay, so why was that person put on puree in the first place? Right? Were they put on puree because, and this is pediatrics, right? So it can vary, but are we on puree? Or do we have a 5-year-old or a 6-year-old that's on puree because they've never transitioned to solids? Because
Mhm.
they were unable to transition to solids, maybe because of, did they have a choking episode? Do they have some oral motor weaknesses? Or are we a 5 or 6-year-old with autism that has some textural sensitivities, right? And that's why we're on puree. Or we have texture sensitivities, but we can eat crunchy, we can eat chicken, we can eat, things, preferred foods, but we just prefer purees, right?
Yep.
So we have to always look at the why. Um,
Mhm.
and Modified barium swallows. Sometimes people say MBS. Some people say VFSS. You know, swallow. Well, for right now, we'll call it a swallow study, right? So a swallow study versus a fees, right? So fees, there's a big misconception about radiation exposure, right? So radiation exposure, many people are hesitant to refer for a swallow study, even when it's available for pediatrics, because they are worried about radiation exposure, right? So that's a little bit of a myth, which we can get to later. But if we're talking about the quality of what we're looking at, right? Because we're looking at the why. We're not just looking at if they're aspirating or if they're not aspirating. Okay? Because yes, aspiration is dangerous. We do all aspirate a little bit though, right? So depending on how mobile we are, right? Depending on how mobile we are, you know, and other comorbidities depends on, the impact of that aspiration, right?
Yeah.
But we all do aspirate. So we're not ending the study right immediately when somebody aspirates. We are looking for what is going on during the oral phase of the swallow. We're looking at what's going on during the pharyngeal phase of the swallow, and we're looking at what's going on also in the esophageal phase of the swallow, right?
Yes.
We are
Yes.
looking at all three phases. Now, in a fees, right? Although there's no radiation, we miss that. We miss the oral phase of the swallow and we miss the esophageal phase of the swallow. We can
Yes.
only see the pharyngeal phase of the swallow. And
Yeah.
we can't even really see the full pharyngeal phase of the swallow because there's
Yes.
blackout periods.
Yes.
We absolutely can use it for clinical reasoning. We can use it. It's great for positioning changes for infants, right? You can trial positioning changes. You can do that with a breastfeeding mother, which is really awesome. But for pediatrics, it's absolutely not my favorite test because it's invasive, right? They are very stressed out. Sometimes they move, which can cause damage to the structures, right? So, and if we're looking for a structural abnormality, a fees is wonderful. But if we're looking at what's going on during the swallow, then we want a swallow study for sure.
I have requested differential diagnosis, like seeking out
Mhm.
the differential diagnosis. My cardiac babies that have
Yes.
turned into cardiac toddlers or children.
Mhm.
So, folks, the vagus nerve, the wanderer that
Mhm.
innervates literally everything,
Everything.
if they've had heart surgery in infancy, toddlers, say, like I have little ones that are 9 and they have velocardiafacial or, different genetic conditions that mean they have to have heart surgeries later on in life. Some of our little friends with Down syndrome. I love a fees because I want to rule out vocal fold paralysis or
Yes,
paralysis, mobility
absolutely.
for my children that we're looking on specifically velopharyngeal insufficiency
Mhm.
versus flaccid dysarthria, and
Mhm.
what is that velum doing to actually close and seal off the nasopharynx so that
Mhm.
we don't have regurgitation through the nose. If I have those symptoms, so we vomit and food comes out of our nose, we have acid reflux and food comes out of our nose, we
Mhm.
have wet gurgly vocal quality, those kind of things, or changes in phonation post surgery, that to me, the fees is great for.
Absolutely.
But those are typically my outliers.
Correct.
Yeah. Love the
Correct.
blue pills.
Oh, thank you.
Sorry.
Thank you.
Yeah.
This is my summer color. I've gotten this color 3 times in a row, and my Tina, my BFF that does my nails,
Yeah.
she is like, "Miss Emma, are you gonna get another color? Because I mean, I'm a little over the blue." And I'm like, "Tina, I'm not ready to be over the blue yet."
Yeah.
Okay? Because it's, it's August 29th today, the day that we're
Yeah.
recording. However, in Boston, it's already fall. So it's cold. And, I consider this a summer color. So we're going to get into the fall colors soon. But I had to take my last opportunity to do a fun summer color. So,
I'm I'm
patient.
I'm I'm switching to purple this week because cross country meets start next week, and my son's favorite color is purple, and his jersey says Mr. Purple, and he
I
has
love
no idea. So I'm going to team spirit with a cowbell and purple fingernails. It's so love
that.
it. Yes,
That's adorable.
yes.
But
Okay,
yes, so again, ADHD, both of us. So back to what we were talking about.
yes.
So I absolutely agree with you, Michelle. Vocal fold paralysis, vocal fold paresis, velopharyngeal insufficiency, absolutely.
Yes.
Now, can you see that on a modified barium swallow study? Mm, no, not really. You can infer, okay,
Yes.
but you cannot see the mobility of the vocal folds, right? So, so in a perfect world, which we don't live in, but in a perfect world, I like both. So, when working on the dream team, I happened to work on a dream team, a few years ago, and we had access to both. So, if we really wanted to or really needed to, we could do both a fees and a modified barium swallow. Now, that is not the reality of life, unfortunately. So, back to swallow studies, right? So, if we're looking at, we're a clinician, we're in the public school system, and or we're in an outpatient clinic, or we're in early intervention, and we are trying to figure out what is going on with this child, right? So, and should we refer for a swallow study? Now, people go back and forth about this. This is a hot topic, and this is probably maybe the biggest one, I have to say, that I don't want to say go back and forth with, but I like to really critical think and problem solve with this one, is food refusal, right?
Yes.
So food refusal. So many, many times, many excellent, really smart clinicians will talk about reasons why we don't refer for a swallow study, right? And if a child is refusing foods, they'll frequently say, you know, they're not appropriate for a swallow study. However, I beg to differ. I actually feel as though if a child is refusing foods, we really should do a swallow study, because what is the reason behind that, right? It's not necessarily, and I'm not saying all clinicians categorize it as behavioral feeding difficulties, but many people do.
Very well.
Many will, many do. We also, we have other practitioners doing feeding therapy, right? Like sometimes behavior clinicians or
Both.
ABAs, you know,
Yeah.
RBTs. It depends on the state and, wherever. But right? And sometimes they'll say, this is a behavior. They're refusing the food. So they're not going to participate in a swallow study. However, right? There are ways, which I teach in my class, there are ways that we make a child feel comfortable, and we can help them participate in the swallow study, because we want to see, are they refusing food because it's getting stuck right here? And
Yes.
that's why they're refusing the
Yes.
certain food, right? Are we is what is going on, right? And there has been many swallow studies that I have done that we see that, right? We see whether it's structure, right, or whether it's a motility issue that we see.
Yeah.
So we can't see like structural, like a laryngeal cleft, for example. We can't see that on a swallow study, but there's certain aspects of the swallow study which you learn when you learn how to analyze that is evidence of a laryngeal cleft. Like I usually at this point now can pick out that's probably a laryngeal cleft, and then they
Mhm.
get referred to ENT for some more testing. But
Yes.
you know, it's not because they're being difficult, they don't like the food, right? Something is going on. Is it an EOE where inflammation is occurring, and that's uncomfortable when they're swallowing, right? Like what is going on? They need esophageal dilation, like something more could be happening that we are that is not just because they don't want to eat the food.
I appear to be running a special right now on pediatric 7 to 10-year-old
Mhm,
boys, all boys. I have 4 now on my caseload.
mhm.
All of the caregivers either have the confirmed genetic markers, the maternal caregivers for Ehlers-Danlos syndrome,
Yep.
or they have outliers, and their sons have the exact same profile, chronic constipation
Mhm,
and
mhm.
or chronic loose stools
Yep.
to the point of significant extension and food refusals outside of the known foods and very unique mastication patterns,
Mhm.
right? And one of the little friends says constipation is so severe that it also results in emesis. And so it's kind of like, okay, we're doing the food refusals, and he told me it gets stuck right here.
Mhm.
And okay, wait list to get a swallow study in the Commonwealth is a minute, right? But having there's also inherent access to, you have emesis in the schools, they're going to send you home, but are we having emesis in the schools because we have an impaction in our esophagus, or we're so
Absolutely.
so like there's all of the, so yes, PO refusals, but the why.
Why, right? You can see
Yep.
we don't modified Barron swallow studies is not the test that we do to determine if we have reflux, right? That would
Yes.
be an upper GI. There's other tests as well. Again, that's not my scope. We're not going to talk about that. But can you see, right? We do an esophageal sweep on a swallow
Yes.
study. Can you see if there's an impaction? Can you see the delay in motility? Or can you see reflux coming back up to the level of the folds to wherever it's coming, right? Sometimes you see it clear as day, and the parents will say, oh my goodness, I can't believe how often this is occurring, right? Sometimes it can happen after every swallow, every bite. Sometimes we do fatigue testing. So, meaning we'll do, if we're testing an infant, right? We'll feed them a bottle, and then we stop fluoro for a bit. We let them keep going. We let them keep going, and then we turn it back on, and you can see the evidence. And we do that with pediatrics as well,
Yep.
because we want to see the process, right? And then we can see, a couple minutes later what is happening, if it's coming back up, if it hasn't gone down yet. So it's really interesting. You also can see, right, mastication. So, we don't keep the fluoro going, right, the radiation on, because sometimes we really have delayed mastication, or
Yeah.
prolonged oral motor skills, whatever's going on here. But you really can see, right, that how long the child is taking. You can turn it back on and see, that they're still working on the food. You can see that pieces it's piecemeal, right? So there's a lot that we can get from a swallow study that we cannot unfortunately get from a fees. But you know so, is it appropriate to refer, right, for food refusals? Yes, I say absolutely yes. And, as you said, the wait list is a hot minute in, I would say, everywhere, truly everywhere. So, what can we do in the meantime? So, who can we get in to see the fastest, right? So, I think that, also rural areas, I understand this is not as easy as pie as in some inner cities, right? But can we now, with access to telehealth, right, as well, which, we're not going to talk about 2026, but, and, I know that this is still state by state, but many states still have access to telehealth services. So, can we see a registered dietitian, or can we see a GI? Can we see a GINP, or can we see a PA, right, virtually, that maybe might be able to refer for some lab testing, and we can see, maybe what's going on with some labs. Can we do an elimination diet, or can we do we need to do some dietary changes to see if changing these foods makes a difference while we wait for the swallow study? Or, what can we really do before while we're waiting for these instrumental tests?
Well, that's where Erin does such a beautiful job of making sure that the caregivers focus on healing and putting joy in the relationship with food. And during mealtime, in
Yes.
the interlude where we do know that an instrumental swallow study is indicated, but we it's going to take the time. But what do you do for the interim and therapy? Yeah.
Absolutely.
Yeah.
Absolutely. And also the parents, right? So if we're not having joy, if we don't have any joy in meal times, right, then we're missing something. We're
Yeah.
missing something.
Yeah. So, Erin, when you're coaching the caregivers, like it's going to take a little time about, to get in for the swallow study, do no harm, keep them safe. And, we're getting into the doctor's appointments for, trying to obtain the differential diagnosis. What what recommendations do you give them to help make in the interim mealtime safe for those early school age kids from like 3 to 6?
Oh, hey y'all. We're coming in
Hi.
hot. I'm like, okay.
Coming in.
Hi, I'm here.
Love
Um,
your shirt.
Thank you. We're really advocating today.
Yes.
Every day.
Yeah, advocating every day. That's fair. She's like, hello.
Here, what are we talking about?
So I think there's a lot of answers to this question, but like my recent shtick has been all about cue reading
Cue
because
reading.
yes.
I was just about to say that, but I want you to go first, and then I have my spiel.
See, we're on the same page.
I know.
Because it's like, and I actually showed this video in my course the other day about this kid I was working with, and we were talking about how to help them explore the food. And I would like, kids give us a lot of cues that we misread or we miss in general. And so being present in the interaction, like I had this kid I was working with, and this was from before, this was a video before, but we were making a smoothie. And I was like, I don't tell them how to engage with the food. Like I opened up a yogurt he never had and he slightly leans in. I'm like, oh, do you want to smell it? I'm not telling him to smell it. He just there's and a lot of our kids that we work with that have trouble with motor planning or praxis or communication, they don't even know how to fully engage in that behavior. So they're like slightly doing something, and it's our job to make meaning out of that cue so that they know that that's something they can do. And so helping caregivers like understand that this is like, why is my thing not moving? Is my thing moving for you?
Yeah.
My line? Okay,
Audio.
great.
Yeah.
Great. Sorry. I'm like, if this is good, it's not recording. Just kidding. But like if we can teach them how to read those cues, it's going to be safe because they're going to be reading what the child's comfortable with. It's when we misread cues and we encourage them to do things that don't feel safe that we get ourselves in trouble.
Yeah.
And I 100% agree with that. And we talk a lot about cue based in infants, right? So this is what we teach in infant feeding in the NICU. We teach with our parent training in the NICU is we're teaching them to read the baby's cues. And there's a lot of research on that, right? And now, we are getting much better at that with older children and older kids. And we have responsive feeding, of course, which is absolutely excellent. And, but the caregiver approach really in training caregivers to read their children's cues and be present, I think that is super, super important. And or if we're talking about, Erin, before you hopped on, we were talking about pediatric feeding in the public schools and what can school-based clinicians do. And that's a huge one, right? Is reading the children's cues or teaching the paras to read the kids' cues, teaching the classroom teachers to read the children's cues
Yes.
and whatnot. Siblings too. We talk about
Yes.
siblings for a second because
Em and I have this conversation a lot, like
I
family members.
family members, and grandparents, my goodness. I absolutely love siblings. I love siblings. I think that siblings can be a huge, huge part of our patient's success, right? Because how often do we want to do what our big sister is doing or our big brother, you know? And I think that I have one little friend that I'm thinking of who's 9, and he has 4 siblings, and he's like kind of right in the middle, and they're all very invested in his success. And it's really wonderful, but that's a lot of pressure. That is a lot of pressure. So
Yep.
they think that they're being helpful, right? But they're not so much. So breaking it down, right? To even to a kid's level, right? To a 10-year-old, 11-year-old's level, even a 15-year-old's level, right? Instead of saying things like, try it, take a bite, you'll like it. I like it like this. You know, there are other ways that we can teach them how to read the cues of their siblings and how to get them engaged and, without pressure.
I I'm thinking back to a mom a couple years ago, and I was working with the infant, and the 3-year-old was adamant that he knew how to feed the baby. And she's like, I walked out of the room and I came back, and he had dropped his entire cup of peaches all over the baby because
Mhm.
the baby needed to eat. And I was like, I love that they're helping, but I mean, like, it was like an infant. So it wasn't, you know what I mean? But like, terrible things could have befallen if it was a different situation. But
Mhm.
yes, but that gets back to, are we engaging in caregiver coaching and empowering them, because I'm running into, I have some colleagues lately that want to pick the child up at the door, and then they take the child back and do therapy, and then they bring the child back to the parent, and in a 2-second, 2-minute handoff, do a debrief, and then there is a significant delay in progress being made. Or I'll add a second scenario in where our scope of practice focuses on interprofessional practice. That means we get signed consent and we advocate on behalf with the other interprofessional practice partners, right? Hey, I'm going to call GI because this is happening. Hey, I'm calling neuro because I'm seeing breakthrough seizures in my session, and I want to quantify what it is that I'm seeing because the caregivers are making the phone calls and they feel like they're not getting anywhere, right? And I know those are two very, very different topics, but what strategies for success do you find in mentoring colleagues and how to be successful with caregiver coaching for intervention and advocacy with interprofessional practice?
I think that that's it. Excellent point, Michelle. And I think that I I am lucky to be able to work right now at an interdisciplinary clinic. So the clinic that I work in right now, job number 7. So one of the yeah. So one
Literally.
of my 11 jobs, I work at it's an outpatient rehab hospital, pediatric outpatient rehab hospital. And we have right now I work 1 day a week. I see kids after school, right? And I see kids during the time of day, right, when they're absolutely exhausted. It's 4:45 in the afternoon, it's 5:30 at night, and they've been at school all day since 6, 7 o'clock in the morning.
Yep.
However, this is the time that works for their family. This is the time that works for their caregivers, right? So what can we do? So in our clinic, we have occupational therapy and we have physical therapy as well. And the good thing about it, the interdisciplinary, right? We have some younger OTs, PTs that come in and out, SLPs. So we all get to kind of we get mentorship and we get to mentor our colleagues, right? And I just recently had this conversation with one of our new grad OTs, and she's so wonderful. She's absolutely excellent. She's an amazing clinician, and she is that she asked me for feedback, and that this was my feedback that I gave her, because she frequently will bring the babies, the kiddos back without the parents. And of course, it is, especially, we call it prime time, especially those hours between 3 and 6 o'clock. That is like the busiest the clinic is,
Yes.
right? Because that's after school, after work, everybody's there. It is wild. It is a wild, wild west, right? Every room is full, every gym is full. We have parents, caregivers, siblings, grandparents. It is crazy. But that is life, right? Life, unfortunately, is not one on one, right? In a private, quiet room, right?
Yes.
With the child and the trained professional. Life really is siblings, grandparents, dogs barking, cats meowing, right? So, how do we figure out teaching them how to do this in the home environment, right? Which is the beautiful thing about early intervention and home-based care. But how can we emulate that in the clinic? So I think what I usually always tell them is we really have to, if we want true success, right? We want is the home carryover program. So sometimes what I'll do in a perfect world, I like to explain to the parent or family kind of what my plan is or what I'm going to be doing, whether I'm going to be modeling without pressure. I do like the caregiver education piece. I try to do that in the beginning of the session or our first session. So that way they know what I'm doing, and then they can kind of watch me and follow my cues. And then, you know, to debrief afterwards, sometimes if we have two parents or a parent and a grandparent, I'll then transition, the child out at the end, and then deep with that parent or other caregiver, and then I can debrief with the other parent a little bit. And I find that to be quite an effective strategy with that parent, that caregiver training piece.
Yes. I One of my favorite resources is the Family Guided Routines Based Intervention with
Mm-hmm.
Dr. Juliana Woods. And
Mm-hmm.
Dr. Frances Burns is the one that mentored me in that tool. But the Division of Early Childhood has a bunch of resources available for how to do caregiver coaching. I know Erin's got great videos specifically where she's engaging with the child and like floor time approach, but she's also coaching the caregivers in why she's doing what she's doing.
Yes.
And that to me is huge because I'm only as good as I build the caregiver up, right? Like we have that scant 30 minutes with them, an hour
Yes.
if you're lucky, but that's it. And so I also simultaneously, when I'm mentoring the new CFs or newer feeding therapists in this, it's okay to be uncomfortable when you're starting out caregiver coach. It's going to be awkward as hell,
Yeah,
especially if
it's
you're not a
hard.
parent. It's hard, but asking the open-ended questions. Hey, how did the strategy work last week? What was your win?
Mhm.
That and giving them the safe space to share their honest to goodness answer and then say, hey, we really struggled this week with this. But finding something positive. People want to hear the positive in the reframe, even in what they may have thought was a loss. Erin, thought? Sorry.
Oh, go ahead, Emma, if you have a thought.
Yeah.
Yeah, I was just going to say, Michelle, I think that that's really, you hit the nail on the head with that one, because the open-ended questions, right? Because I frequently, or previously I should say, no, I would say now as well, because sometimes lifes, right? Life is always lifing. Okay, parents are busy, clinicians are busy, right? Productivity standards, right? A lot of clinicians are jam packed, session to back to back to back to back to back, right? So sometimes you blink and it's, let's say you see a child every Tuesday at 3 o'clock, you blink, it's the next Tuesday at 3 o'clock, and you're
Yeah.
like, oh my goodness, right? So,
Truer
and
words.
yeah,
Truer. You're
okay,
like, oh shoot, I didn't do that thing.
I didn't do that thing, right? And this is on both ends. This is on our end as clinicians and their end as parents, right? So, you know, with parents, I frequently will ask these questions, right? Like, how did A, B, and C, D go? Or how did, how are you feeling about A, B, and C? And sometimes they'll say, oh, oh my goodness, we didn't get to that. I completely forgot about that. Or to be honest, we were not able to get to that this week. But it puts the accountability back on the parent, right? And or vice versa, the clinician too, when we forget to do things or didn't have time to do things or whatever it may be. But for the parent piece specifically, it brings the accountability back, and then they say, you know what, I I've got to do that this week. Like that is my goal this week, is to try A, B, C, and D, because it really worked last week when, we did it together, or when you did it, or you modeled it, or whatever. So I think that, and I always say, this is a judgment-free zone. I am not here to judge you. I completely understand. This is not a judgment. I'm here to support you as best I can. Is there anything that I can do that can help you practice this strategy or whatever it may be? Can I print something for you? Can I, do you want me to call dad on the phone? Do you want us to take a video of A, B, C, and D, so you can explain to grandmother, to nanny, to babysitter, to daycare, and they can also implement whatever strategy we're working on. So I think that those open-ended questions are super, super important, because so many times we get this used to happen to me frequently, before I really honed in on the caregiver training, is, we get to the end of the episode of care, and it would be like, I feel like we're making so much progress when we're here with you, but then we get home and it's like, it does not translate to home.
Hear
He does
you.
not act like this at home.
Yeah.
And then we're not doing our job correctly then, right? Like if it's not translating to the home environment, we have to fix something. We have to fix something because we don't live with them at their houses, right? We can't. It's got to translate. Or I frequently get, you know, this is awesome, great, we're all ready for discharge. And then I'll get a phone call a few months later, hey, we've hit a regression, or, we really would like to come back for some treatment sessions because we made so much progress with you and now we're not making any progress at home. And then you do the reflection questions with the parents and it's like, oh, well, you're right. I should have been doing it. I haven't been doing, wait, I haven't been doing A, B, C, and D. And they start to realize like, oh, I am a part, this is a holistic care here, right? So I am a part of this process as well. I have to do my part to help my child succeed.
Yeah.
Yeah.
And I think like you said, I try to be very like vulnerable in my own way so that they don't feel because I think, as well-intentioned as people can be, like they can non-verbally be putting pressure on the family. Like they can, the way you say it is very important. So like making sure to, like I'll say things like, yeah, I mean, I forgot something or something like that. Like totally understand. Like, were you able to work on this week? If you weren't, it's okay. This is just going to be really important kind of, but like really the way you say it is important. So they feel like they can be honest with you, because you can get into a rut where like the family's saying, oh yeah, I did this. And you're like, it's okay if you didn't, but you want, like, it's more important for them to be honest with you, because if it is too much too, like if they really don't have the capacity to be doing what you're asking them to do, like they really can't, then I can give you maybe one little thing and at least you can do that. So like if we can give them those opportunities, that can be really helpful, because it can be a lot to just like change something. But my job is also to make it functional for you and your family, because I think where clinicians get in trouble too, and like in all the like floor time caregiver coaching, we talk a lot about you as the clinician may be able to get the kid to a certain capacity that's a little bit higher than the caregiver can get them, but that doesn't matter. It's more important for the caregiver to help support them in that capacity, even if it's not quite the reach that maybe you with all your skills could do. And that's okay. It's not about you getting them to do the thing perfectly. It's about the functionality of the family supporting them in that, especially when it comes to feeding.
And Erin, I think I love that you said that. And I think that that's really important to talk to caregivers about that when you start treatment, because I think that this is a huge misconception with therapy. And I think that this stems from many different areas. I think that it stems from the way physicians frequently talk to parents about therapy. I think that this is not a blame on physicians at all. I think that we all have work to do in this area, but what is therapy and what is the purpose of therapy, right? So I think we're here to talk about feeding therapy, and we're talking about feeding therapy specifically, right? I'm not talking about physical therapy. I'm not talking about anything else. But our jobs, right, is I think that sometimes parents come in with this idea that we are here to fix their child, right?
Yeah.
And we can fix them in 1 hour a week, or 30 minutes a week, 1 hour a week, and that is going to fix the problem. And, that is where we run into trouble, right? And parents are upset at the end of treatment, that we haven't made enough progress, or A, B, C, and D. And I think having these conversations at the beginning of treatment when we're first starting is super, super important.
I like to call it laying my exit strategy,
Yes.
because you don't want your little one in therapy forever. And
No.
and certain diagnoses will make you eligible. Like Christian's brother will always be eligible for
Our kids
OTPT.
with Down syndrome will always be eligible for
Yes,
therapy.
Mostly autism also.
yes,
EP, right?
yes, is it clinically appropriate in this moment? And what are realistic expectations? So, and that's something that's hard to learn because our realistic expectations for pediatric feeding therapy are still being discovered. We have to have a basic understanding of what are the typical neurodevelopmental norms, because
Mhm.
there are typical norms from a capacity to chew at this tensile strength, for how to chew, for what is safe. And those norms, Dr. Amy Delaney is and others,
I was just
like,
gonna say
yeah,
Marquette.
yes, Marquette's leading this. We've
Yes,
got
they are.
Georgia Malandrecki doing huge work in it. Like, we have that information coming, but then how do we wrap that information into consideration with this is what the child's unique medical diagnosis or diagnoses are, and then wrap it into and this is where I'm going to segue to Erin to make sure I'm using the correct terms, a strength-based neurodiversity affirming. Are we acknowledging that child's own unique preferences? And then wrap all of that in, but what does the caregiver want to work towards? Because so much early intervention, if we take this back to the tiny humans, the birth to 3 population, the IFSP is supposed to be written predicated on caregivers' goals. But does the caregiver have the knowledge to filter all of those factors, neurodevelopmental norms, child's unique medical etiologies, and child's unique preferences? Can they filter that through the sieve of life to get to this is a realistic goal that we can work on? And put that back on us as the clinician. Do we have the skill set to have that hard conversation, and where do we go for the mentorship to find to learn how to do that? Yeah.
And I think that you are absolutely correct. And we are jumping absolutely all over the place. But I think that we can circle this all the way back, right, to what we originally started talking about, right, which is referring for instrumental studies, right?
Yes.
When to refer for instrumental
Oh, that's
studies.
how we got here. Okay.
That's how we got here. And
Yes.
whether we're
I'm with you.
yes, whether we're referring from, we're trying to figure this out from an outpatient clinic, from home health, from the school system, what is the realistic expectation, right, of where in the why, right? Why are we, what are the goals for the family? What is the goals for the caregiver, right? And I think that we're finally moving towards there are, lots of change makers in the field right now, which is absolutely amazing. But we're moving towards the neuroaffirming approach, and we're moving towards better, more consistent research with neurodevelopmental norms. So I think that both of these things will really, really help us all reach the same, destination.
Yes.
Does that make sense?
Yes. Okay, but what do y'all do when it comes to mentoring or having the conversation about I need to engage with this interprofessional practice partner? Or
Like when they're asking how they do that?
yes, like I had a conversation come up today, technically yesterday morning, where they were like, "Well, how come you have to call the GI?" And it was from a colleague.
Mm.
And I was like, "Oh, because of my scope of practice." And they were like, "But why is speech calling GI?" And I was like, "Ah, well," and I went through the 4 domains of pediatric feeding disorder. Conversations like that get me really excited, and I go super intense nerd, and I probably don't need to go that far down into the weeds, but it's like this is a teachable opportunity to talk about like my scope of practice and like what it is that we do, but that's
Well,
something that comes up regularly.
people have a misunderstanding of scope of practice versus scope of understanding. So, like, my scope of
Oh,
practice, you know what? I just came up with that.
I
I
really
like
like
that.
that. Yeah.
Great
My
point.
scope of, and I talk about, this comes from my floor time lens of like, I understand a child's individual differences, their motor planning, their sensory system, all of these things, but that's not what I'm treating necessarily. It's the same with feeding. I'm not treating the reflux, I'm not treating the allergy, but I need to understand it to be able to filter that with how I'm treating
Yeah.
that child. And that's where people get a little bit lost. So, And people don't like it, and they are like, well, I don't want to call the doctor. Guess what?
You have to.
You have to. I'm sorry. I can give you, you can email them if you want to. You have to call them. You have
Yes.
to have them hear your name. This is
Yes.
how you build relationship. It's really hard at first, but it gets so much easier. And then eventually you get their cell phone number and you can just talk to them, and it's fine. And it's so great. And they like that, actually. The good ones, not everyone, but the good one, you'll find the good ones, because the good ones will appreciate you reaching out, will appreciate your perspective, will be like, let's just take this to the cell phone, and then you'll have them in your back pocket. And it's like, it's so important. And that's also helping the caregiver, because how hard is it for that caregiver to have to communicate all of that? They go to the appointment, the doctor's like, they're fine, and you're like, well, no.
Not
So
really.
I know people are like, well, I don't like to call them. Then fax your report, maybe, but I think you should still call them. I think we should still get better at that.
Yes.
Yeah. Yeah. I absolutely agree with that. And, I, it's tough. It's absolutely tough. But also, you can frequently, when you call the doctor's office, you can get the nurse or you get the front desk staff,
Yes.
and you can leave
Yes.
a message for the
Yeah.
doctor too, right? You don't actually necessarily have to talk to the physician. Sometimes they'll call you back, sometimes they won't. Sometimes the front desk person will give you their email. You can shoot them an email. There's many, many ways to communicate with physicians, but we absolutely have got to be communicating with physicians. I really fully, fully support and agree with that and teach that, having these difficult conversations, because, and we talk about this also, Michelle, we've talked about this in the past too, is the white coat syndrome, right? Like, we
Yeah.
are always, so many people, professionals have this, concept of white coat syndrome, right? Where like the doctor is
Authority.
authority, right? Authoritative. And yes, they are the leader of the team, right? Like, yes, they are leading the team, and it is their license on the line, or their liability if something
Mm-hmm.
happens, right? If they recommend something or refer and something happens, right? So I understand their hesitancy for certain things, but doctors are just, I say this all the time, I say this to my students, I say this to my parents, I say doctors are just people. They're
Yeah.
just another person.
You work
Yeah.
with enough residents, and you know that they have learning to do too.
Yeah.
Yeah. Yes. Residents are baby doctors, right? Like, they
Yeah.
do this all the time. They're baby doctors, right? They're still learning. There are many, many of them are still learning. I think that's, when we're talking about acute care, or we're talking about the hospital system, that's a whole different spiel we can go on. But if we're talking about, outpatient school system, early intervention, outpatient clinics, right? And we're talking to usually pediatricians, right? We're talking to pediatricians, or we're talking to GIs or ENTs, right? And I think that these are usually attendings most of the time. So, and I think that, again, we do know what we're talking about. We have to have confidence in our skill set. They have a skill set. We
Yeah.
also have a skill set. We
Yes.
can still educate them. We can educate each other. They don't know everything. We don't know everything, right? But it is important for them to know our perspective, where we're
Mm-hmm.
coming from, the why, right? Frequently I explain my why. Physicians, I think, nobody takes well to being told what to do, right? So I think that telling a physician something versus, explaining the why, I is a
Mm-hmm.
much different approach, and you get a much different outcome with that
Yeah.
approach.
Letting it be their idea. Oh, and you also have to remember, not a lot of therapists reach out to physicians.
Right.
So it's like they get surprised almost when you call them and like explain to them why, a lot of them will just get a kid sent to them by a therapist, and they like don't know why, and
Mhm.
they're flying a little blind. And so it's
Mhm.
like, when you do reach out eventually, like they do respect that. Very, they may not love it, not all of them, but they will respect it, because it shows you care about their kid. And if you're somebody who's also trying to like build your, practice, or build your reputation, like that goes a very long way, because they trust you more, because they know you're going to contact them. They know that you're not just like, and then they're going to learn from you too, because like some physicians just think, oh, I send them to a feeding therapist, and they just like do the thing. Or some physicians don't even really understand feeding.
What
And
we
so it's
do.
like, the more conversations,
What we do.
give them the benefit of the doubt too, of like, let's help each other learn.
Absolutely.
But
Absolutely.
that goes back on us because
Mhm.
interprofessional education and interprofessional practice is part of our scope of practice.
Yes.
And when you work in the capacity as a mentor or a clinical supervisor for either a student or a CF, or if you're like a lead SLP at your site, then we should be teaching our colleagues, hey, here's a sample script for how you can hold this conversation. So, because there's something
Mhm.
beautiful about having a sample script. It will not go according to what the script says, but
Oh, no.
like that opportunity for like bullet pointed ideas just to help empower the next generation is key. Okay,
I
now
have this in my course that I teach as a
yes,
part of that. We have a script and I have an email script and we have a verbal script and then we do practice. We'll do role playing.
yes,
I partner everybody and we do role playing and one person plays the physician, the other person plays the SLP. And sometimes we'll do a group of three and we'll have the parent be a part of that as well. And we have these conversations and then, we always throw a wrench in there because it's true. You don't know how these conversations are going to
yes,
go, but it's so much better to be able to practice with a friend, a colleague, another SLP,
yes,
when you're in a class in front of, a small class, but you're in front of people where there's no pressure and then be able to, practice these conversations to have with the physicians.
yes. Okay, so I am quadruple booked today and have to run and feel like a schmuck because we could talk to you for like from ever. Sorry, that's a bear quote, forever, because he had from and for backwards and we still say from ever. But how do people are going to want to learn more from you? So how
Yes.
do they find you? How do they learn from you? Give us all the details.
Yes. So I say there's there is a lot of ways to learn from me, which is wonderful. I am, all over the place, which is great. Sometimes I do guest lectures, sometimes I do my in-person class at the Swallowing Wellness Center. So the best way to kind of find me and figure out what I'm doing is to find me on Linktree. So it's just linktree.com/Emma Justice. And you can find me, what I'm doing, what's going on. You can book a meeting with me. I do caregiver coaching, clinician coaching. I do lots of things, but you can talk to me 30 minutes, $30, and we can chat and figure out all the things if you have any questions. And you can see what I'm doing next, if I'm going to be teaching in person or virtually or whatever. But Linktree I find is better because then that also links you to my social medias as well too, which you can find information as well.
Nice. Okay. Now, if somebody has funny monies and they want to make a donation in your honor, where
Yes.
can you donate to?
I absolutely love that. And there's information on my link tree for that as well. But March of Dimes. So March of Dimes is my biggest, I'm on the committee for the March for Babies for March of Dimes. I'm super, super passionate about that, especially as we're talking about caregiver education, caregiver support, right? That focuses on that nonprofit focuses on NICU families, NICU graduates, maternal infant care, but also dads too. We're really getting into the dads, which thank you. Finally, everybody's getting into supporting dads, which is just as important. So, March of Dimes, absolutely. Please make a donation.
Awesome. Thank you. Thank you for being you and for coming.
Thank you
Yeah.
so much for having me and inviting me. This was absolutely awesome. I love talking to both of you guys, and I love the open and honest communication that we can have without pressure. I think that it's very important to be real, especially in this day of, you know, social media and everybody trying to be something. I think that it's important to show people that we're all just humans here. All of
Yeah.
us, we're all just humans. So
Yeah.
let's be humans and have human conversations and, you know, support each other, lift each other up.
Yeah. Awesome. Okay. Thank you, hon.
Thank you guys. Enjoy the rest of your day.